So I think there are around 56 or 57,000 cases of breast cancer every year. It affects 1 in 7 women. You can't really be a lazy GP. It's impossible. His experience, it really took me back to what life was like being a junior doctor. A doctor will commit suicide once every 3 weeks in the UK.
Hi, I'm Hala, your host today. We'd love your support. A quick subscribe to this channel would mean a lot to us and help us grow. We may be small now, but with your support, we can achieve something amazing together. Thank you.
Welcome to the Visionary podcast, where we discuss science, medicine, physical health, and mental well-being.
I wanted to ask you about if there are any lifestyle changes in terms of diet, exercise, whatever, that I could make to keep my breast healthy. Then I stopped and I thought, I don't know what healthy means, because we know breast cancer, but can I develop any other conditions in my breasts?
You can develop cysts and fibroadenomas. You can develop obviously other skin, sort of fatty tissue, fatty lumps and things like that. So you can have other things that can cause changes within the breast, which are not cancer. However, you cannot necessarily differentiate those just by self-examination. So if you ever find anything that's different, it's always better to be checked and for that diagnosis to be made first before. So with anything to do with the breast, any changes within the breast, you always think of almost worst case scenario, could this be a cancer? And then rule that out and then you'll know what the other things are. Yeah.
I read a while ago that some women worry about bras and underwires and deodorants. I myself stopped using deodorants like a year ago to avoid chemicals. Is this something I should worry about? Is there a guideline here?
There isn't any evidence at all yet that there is any. There is a lot of sort of talk about it, I think, if you go onto the internet, but there is no evidence that any of those things cause cancer. I do see a lot of patients who come in with pain caused by underwire bras or ill-fitting bras. I give advice on that, but there's no link between those at the moment and breast cancer.
How common has breast cancer been over, let's say, the last 10 years? Do we have statistics on this?
So I think there are around 56 or 57,000 cases of breast cancer every year.
50 or 60,000?
Yes, of breast cancer. It affects 1 in 7 women. So it is the most common cancer affecting women.
What do you think of the view that breast cancer wasn't as prevalent in the 20th century? Is there any truth to this?
As far as I'm aware, the cases are continuing to increase. I mean, it's difficult to know from that time because women obviously are living much longer than they did in those days, and most cases of breast cancer tend to occur in older women. So we're also able to detect cancer much better than obviously we would have done years ago. So,
and how often should we have mammograms? Every year?
Every 3 years.
Every 3 years. And do you think this is a safe interval to ensure early detection?
Yeah, I mean, there's obviously been a lot of research that's gone into choosing 50 to start screening and choosing every 3 years as an interval. It's always very difficult with screening because, women, you've got to, it's not, going for breast screening is not the most pleasant experience always. It can be quite uncomfortable. It can be a bit embarrassing. You've got to have an interval where women would be prepared to come, and obviously the anxiety that's created when you go and have a screening. It's not something you're going to want to do more regularly, and hopefully they will pick up the majority of cancers if they're screening with that interval.
The very first doctor who checked my breasts 25 years ago said to me that my breast tissue means that I'm less likely to have breast cancer. I didn't know what he meant, and I still don't know what that means. Does that mean anything to you?
If you've got denser breasts, dense breast tissue, that can mean that you're slightly more likely to develop breast cancer. So that may have been what they were referring to. So if you don't have a particularly dense breast tissue, then your chances of having breast cancer are perhaps slightly less. But I don't know whether, as a patient, how useful that is going to be, because
you
can't change it, and you wouldn't want, there's still a chance that you could still have a lump. So I would hope it wouldn't influence your self-examination or anything else. So
my mother-in-law had cancer 9 years ago, actually, when she was, when I was giving birth to my only child. She was at the same hospital getting chemo, and 9 years, and she's an old lady. She's still alive and she's doing well. What are currently the most effective treatments of cancer? Are we still at chemo?
We are for some women, and radiotherapy. We are also now using a lot of the endocrine treatments. So we have two medicines that we use. Tamoxifen and medicines, and there's several different names of them, but letrozole is one of the main ones. And these work by blocking hormones. So these are used for the estrogen receptor positive breast cancers. And they have been shown to be very beneficial as well for preventing recurrence rates. And again, most people tolerate them very well. So these are often treatments that patients will be given after they've had their initial treatment, and that might be chemotherapy, it might be radiotherapy, it may be surgical, lumpectomies.
HRT and cancer, we touched on that. We know that they have a very complicated relationship. Where does the complexity come from?
So if you have an estrogen receptor, if you have a breast cancer that can be fueled by hormone, then taking HRT is of concern that you could then develop, or it could stimulate the growth of further cancer. So if you are unlucky enough to produce breast cancer cells that respond to the hormones that you have from HRT, that's then going to encourage those cells to grow into tumours. It is actually quite an interesting area. And I had a recent discussion actually with a colleague of mine who is a breast oncologist. And she was saying the reason that this is so complicated is because there is not one rule that fits all, unfortunately. Every single woman's breast cancer is different. And you have to tailor the treatments that you're offering to that patient on a very individual basis. In terms of risk of recurrence, that is also very different from patient to patient. It may well be that we are being overcautious with some women who have a very low rate of recurrence, and therefore we're denying them potentially hormone replacement when actually it would be really very safe. But there are some cases of some women where it would be extremely dangerous for them to have this hormonal treatment. And there are some really good developments and interesting developments that are going on now looking at how we can identify these risk factors for women more precisely and individually, again, using sort of AI technologies and things like that, which may be able to give us a greater predictive value of how having additional hormone treatment how much that will significantly impact that individual person. So it's encouraging that these things might well be on the horizon, but at the moment it is very difficult to really make that judgment about how safe HRT would be.
Some women feel stuck between wanting relief from menopause symptoms and worrying about their cancer history. It's a big decision, isn't it?
Yeah.
Okay, when might HRT still be an option for cancer patients?
We would then have a discussion with them. It doesn't have, I'm making out that it's only if they have very extreme symptoms, but it's a discussion that has to be had based on the risk and the benefit, and a decision has to be made jointly between the person prescribing the HRT and the oncology team, so that the patient can make a fully informed decision to be able to make that decision.
I have a cancer diagnosis, or I have treatments, and now I decide to take HRT. Will there be more monitoring or extra precautions?
If you're taking tamoxifen, for example, which is a tablet that you're prescribed, one of these endocrine treatments, you would be monitored anyway more regularly after you'd had your cancer treatment. But otherwise, I don't think that, as far as I'm aware, there's any particular guideline that would then, if you had a past history of breast cancer a long time ago, you weren't on any treatment, and you decided, or for whatever the decision had been made, that you were then going to start hormone replacement treatment. I don't think there is any guidance to suggest that you should have more regular monitoring. And I think, again, this is simply because there hasn't been the research and we don't know what the evidence is around what we should be doing.
Medications. On the subject of medication, how would you decide as a GP that medication is the right route versus lifestyle changes? Is there a blueprint at the back of your head for this?
Yes. I mean, I suppose you build up your knowledge of certain treatments and you know what things, you know which treatment, which conditions are not simply just going to be treatable with lifestyle changes. And then you are going to need to prescribe a medication because you know that it's not likely to improve unless you do. So for example, if someone has an infection, you know, you're going to need to prescribe an antibiotic to that patient is the only way that of a particular type of infection, an antibiotic is what's needed. But there are other conditions where you can go either way. So for example, if you're looking at mental health, mental health is something where it's very important to have a discussion with a patient to allow them to make a choice as to what they feel would be beneficial for them. Some patients very much like a medical model and would say, I just want a medication, please. That's what I want. I want a medicine. It's easy for me to take a tablet every day. Can I just try that first? Other patients will want to avoid medication at all costs and would much prefer to look at things. Yeah, would much prefer to look at things holistically or consider other options. And there are obviously a variety of different symptoms where that's an option, and there are some where that is not an option. So,
of course, we talked about the 10-minute appointments in the NHS and how this might not be enough for some GPs to explore holistic approaches. Do you think this might lead some GPs to overprescribe medications?
I think it does. Yeah. We'd like to think that it doesn't, but I'm sure that it does. And I'm sure if I was being totally honest, it probably has happened to me as well, that, you know, you're seeing a patient, you're perhaps busy, you're running late, you don't have time to really explore all possible options with that patient, and they come in with something fairly straightforward that you know will probably just be sorted quite easily with a medication. It's very tempting, therefore, just to say, I know this is probably going to work, just try this and off you go, and not really go through all the possible other scenarios that you could consider. I do try to do that, and certainly with conditions like mental health, I will always explore those other options. But it does mean it's going to take longer, and when you're under time pressure, we're only human. I think sometimes you are going to just go straight to the point and say, this is what you need, off you go. You know,
is that a tension or a point of internal conflict for some GPs?
Yes, I think so. Yeah. And I think, you know, I'd like to say it doesn't ever happen, but I think, you know, we are all possibly, or we can be possibly slightly guilty of that at some point.
Okay. Yeah. One last question about medication, please. If I were prescribed medication in a 10-minute appointment and wasn't enough time to explore the side effects or how the medication works, where do I go? Online, hopefully, to explore that because the NHS website doesn't have everything, it doesn't cover everything.
I mean, there should always be, any medication that's prescribed to you should always come with a leaflet inside the packaging, which should always list all the possible side effects of the medication. It's a little bit of a difficult one. I certainly find some of my patients will read that very intently. And some patients, I think, are so paranoid about side effects that even the very minor, slight one, they might report that, you know, they'll start to almost imagine that they're having side effects sometimes, I think, because they're often very anxious about taking a particular tablet or medication.
Self-fulfilling prophecy. Well, the thing was they list everything. And of course they are, it's legally binding to list everything.
Yes,
and
so that can be a bit overwhelming.
Know whether this is the most common that I should be aware of, or this is minor, the percentage.
Yes.
So it's these kind of things. And they don't mention how the medication works.
No, there is information on, I mean, patient.co.uk or the NHS website is probably as reliable as anything. There is also, you can go onto the British National Formulary, which is the formulary that we always use to prescribe from, and that will have information. You can go online and look up a drug, and that will give you a list of common side effects, and it will list them as common, rare, less rare. But it is, I completely appreciate it is really difficult because those leaflets are quite overwhelming. And as you say, it almost lists everything and might even put you off wanting to take a medicine. And then actually in reality, a lot of medicines don't tend to have that many side effects. And I do always try to counsel patients and explain what the common side effects will be. But obviously there are always going to be side effects that can happen to a few and can cause a lot of problems as well. So.
Fiona, you work at Benenden Hospital, which is a private hospital. The team at the hospital, including yourself, have set up a health assessment unit for women. Why? Surely the hospital had something in place already.
The idea was really to try and create a space. And this came about really from research that Benenden Health had done, looking at, how women were feeling about not being listened to, not having their health concerns addressed. And we wanted to really have something that would look at women very holistically. And then we can then refer those women, if needed, to other services that can be provided by the hospital, but could also be provided by the NHS as well. It's just really giving information and allowing women the time and the space to be able to explore that.
I'm wondering, how does working in the private sector differ from working in the NHS?
So the main difference for me, so I do both. I do mostly I do NHS work, but I do a couple of sessions a week at Benenden. The main issue for me is time. So it's just that I have a longer appointment time with my patients.
How many minutes?
So in the female assessment clinic, I have 45 minutes with a patient.
Wow, that's
and in my normal GP clinic, I have 25 to 30 minutes per patient. So it just means that we have the time and the space. That can mean we can have 25 minutes to discuss one problem in great detail, or some patients will bring in a few different things that may or may not be related, and they feel they have the space to be able to talk about that.
Well, we know that paying for healthcare usually means longer consultations, but what are the other less obvious differences that we patients might not be aware of?
Between private and
the private sector and the NHS?
I don't think you get the waiting times for things are shorter. Yes. So you'll be seen. You have more flexibility about when you're seen, and the waiting times will be shorter. So if you want an opinion on something, you can generally get an appointment with a private doctor much more quickly than you would on the NHS. In terms of the quality of care, there are a few services that are available to private patients that may not be available to NHS patients. But these tend to be, I wouldn't suggest that these are necessarily core, what we would refer to as sort of core treatments.
Like what?
So for an example, there's a service at Benenden, which is called a Mona Lisa, which is a treatment for women who have vaginal dryness and vaginal soreness. And this is a service that just isn't something that's funded by the NHS, so it's not able to be offered as an NHS treatment, but it is something that can be funded at Benenden, that's provided at Benenden as a private care. But in terms of your core main medical issues, I wouldn't suggest that you get a better service. It's just that because most of the specialists that you're seeing, the doctors and nurses, they're people who work in both sectors, NHS and private. They've all got the same credentials and qualifications. It's just more to do with time, really more than flexibility, perhaps more than anything else. Yeah.
Do patients expect more from you in the private sector compared to the NHS? Are they more demanding?
I personally, I don't find that. I think before I went into the private sector, I was worried a bit about that. And I thought, are people going to come in and demand certain things, and I'm going to feel uncomfortable because I don't really agree with what they're demanding, or I don't feel it's appropriate to be referring them. And actually, that hasn't been my experience at all. I don't feel that they are more demanding. I find the majority of people that I see in my GP clinic at Benenden mainly are people who either find it very difficult to access their GP because of the difficulties at the moment with NHS GP access, or they're people who just want a bit more time because they just feel they're too embarrassed to ask, about several different problems or something like that. That tends to be the main majority of people who come, and I don't find them in any way demanding. They often just want an opinion. They want to speak to somebody. Sometimes they haven't been able to get a face-to-face appointment or something like that.
I want to gain a small glimpse into your life role as a GP. We don't usually hear how our GPs function under so much pressure and accountability. You guys are being judged personally and professionally with every single encounter, every decision you make. How do you deal with this kind of pressure or tension on a daily basis?
I think it's just something you build up and then become used to, but it is quite an exhausting and very busy, full-on job. I mean, it's not something that you can do without giving it 100%. You have to be absolutely on your A game when you're going into a day of general practice. And I think it's just very important that you have good support around you and that you work well as a team, certainly at Rye Medical Centre and at Benenden to an extent as well. We have the most amazing team around us, and that is critically important. And all of us play a role, and we all support one another. And I think, that's important. I also have friends and other medical colleagues that I have a group of other GPs who are not from my practice that I meet up with regularly. And I have friends from medical school and people that I've worked with in the past who I regularly have conversations with. And sometimes that's just sharing incidents, things that have happened. How would you have managed this differently? Sometimes you're just blowing off steam. But all of these things are things that I've always had to do over the last 20 years.
My personal view is that we don't appreciate our GPs enough. We miss appointments, we take them for granted because they're there all the time. They're never gonna refuse care, and they wouldn't refuse care. What are some of the misconceptions that we patients have about GPs?
So I think one misconception is that it's just a free thing, in a sense that this is just something that's there. So if people do miss an appointment, that is costing the NHS money. So it's cost about between £30 and £40 when you miss a GP appointment. So that is something that's worthy of noting. I think sometimes people have misconceptions just in terms of our knowledge. I think, as GPs, we are generalists, which means that we have a very broad knowledge of most aspects of health, but we don't have the very, very detailed knowledge of certain things. And that's why we refer over to specialists. And I think, sometimes people might forget that. They might not understand that some GPs will have particular interests in some areas and be very good in that area, but there might be a colleague who would be a better person to see for something else. And then I think also the third thing is that recently we've had a bit of a bad press, and I think
I'm not aware of this bit. Gossip.
Well, no, but I think maybe as GPs we see it more than we see it. But I think there is this anger and frustration because of waiting list times, because it's difficult to get GP appointments, and patients don't always understand exactly what the reasoning is behind that, and they feel frustrated. And I think some of the ways that GPs have been portrayed on social media, perhaps in the media, general media, as being sort of, GPs are just part-time workers. They're they're being lazy. They're not working as hard as they used to. They don't want to see patients anymore. I think sometimes there is a bit of that can be that's sort of coming up a bit more, which can make people quite angry and frustrated. And I don't know how much notice people take of that, but I think when I read that, it makes me sort of feel a bit upset, because I understand exactly that you can't really be a lazy GP. It's impossible, because it's so much work. You just couldn't do the job if you were lazy, and not understanding how we work and sometimes the pressures and the stresses that we're under. But then equally, you don't want people to think that so much that they then won't come and bother you, because obviously we're welcome to see people, but it's just it's a busy job.
Absolutely. Even I am outside the system. Of course, I've dealt with lots and lots of GPs and consultants over the last 15 years, but I can just imagine the long hours, the admin work, the stress and the responsibility of being in charge. And I have, I say recently, in the summer, I've seen a moment of genius in my GP. I'm not going to name him, but one of my GPs in Rye Medical Centre, I think part of being a GP or a doctor is to be a good researcher.
Yeah.
And I had, I don't know if I should tell that, I had a sweat rash under arms from playing tennis, and I spent the whole day not showering, spent the whole day in the office, and I had that sweat rash and it wouldn't go away. I was giving medication and the cream and all this of that, and it went on for months. I was like, oh, what's going on? So I went to see him again. He looked at my medical history and he said, you had psoriasis. in the past, yes, I still have psoriasis. And I was so afraid that he might think it's psoriasis. And in my head, it's not psoriasis, not, you're looking in the wrong direction. I had a sweat rash, and I did respond to an extent to the medication. I was just sort of about to correct him, but I hold my horses. Then he went to a specific website and researched things quickly. He was genius. He said, "You have psoriasis." No, I don't. No, because there is, I didn't know the ins and outs of psoriasis. There is a special kind of psoriasis called fluctual psoriasis. Initially, it was a sweat rash, and it responded to a limit to the medication. Then it triggered psoriasis, and he was able to figure this out in just 2 or 3 minutes. Oh,
yes, yeah.
I said to him, "You're a genius." So it's just brilliant.
Yeah.
Now, about the hard work again, how many patients do you see a day at Rye Medical Centre?
It varies a little bit depending on what types of clinics we're doing, but I would say probably about 30-ish, something like that.
Wow.
Yeah.
How do you balance patient care at the time that you invest with patients face-to-face or over the phone with all the admin work that you have to do?
It just makes our life very busy. I tend to do a lot of the admin work outside of my clinical days in the surgery. So I'm in my NHS practice for 2 full days, which tend to be quite long days. But I have a laptop which I can log into my network, and I will often look up, do a lot of the admin work on the days where I'm not at work, so that I'm ready, so that when I'm in work, I am just focusing on the patient appointments and then the admin work, which I can't do outside. So blood test results, letters, we get lots of messages continually throughout the day, patients making queries, those sorts of things. Those things I can often answer in my own time.
In your own time?
Yes.
Okay. Before becoming a GP, did you have any idea how much admin work you'd have to do?
Probably not.
Yeah. Was the reality a shock?
Yes, I was very, very, very fortunate at Rye because when I joined as a partner, I think I was very lucky that I had a very gradual introduction into the certainly from the business side and the partnership side, admin. I had a very sort of gradual introduction into that, which I was very grateful for, because I think if I had just been thrown in at completely at the deep end, because we're trained at medical school to look after patients, and I was fairly confident about that. But the running of the business and how you negotiate the GP contract and how you work with the local authorities and all of those things, I really wasn't particularly aware of how to manage all of that and how to run a business. So I was very lucky. But yes, there's patient admin and then there's business admin as well. Yeah. So there is a lot. Yeah.
There was that medical drama / comedy on the BBC like 3 years ago. It's called "This Is Going to Hurt."
Yes.
And it did hurt.
Yes.
Yeah. It's painstaking.
Yes.
Candidate.
That hugely resonated with me because it was exactly his experience. It really took me back to what life was like being a junior doctor. It really was, I felt a very accurate portrayal of what experience I know obviously there was a very tragic story within that, which is not something that I experienced, but just the general way of being a junior doctor in that environment was very familiar to me.
We'll add the link in the description if anyone wants something raw and painful. Yeah, the tragic story, it's, I think you're referring to the junior doctor who couldn't take the pressure of her job and eventually killed herself. We don't hear much about how GPs and doctors deal with the pressures and the physical and mental pressures of the job. Are mental issues a common thing between doctors?
They are, unfortunately. A doctor will commit suicide once every 3 weeks in the UK. So
a doctor, let's hear this again. A doctor will commit suicide?
Every 3 weeks.
Every 3 weeks?
One doctor every 3 weeks in the UK.
How come we don't hear about this?
Mental health problems are very significant amongst all healthcare professionals. It's not just doctors, it's anybody working in healthcare. It isn't something that is spoken about a lot. I think there is also a danger amongst the health profession that doctors will often be reluctant to seek advice. maybe because they're concerned that that will impact on their ability to practice. Obviously, we have a responsibility that we should be making sure that we put our health first, because we don't want to put patients at risk. But it is a very real problem, and we are very aware of that.
This is shocking, very shocking to me. I guess you spend the whole day listening to other people's worries. How do you look after yourself?
Yes, I have an incredibly supportive team. So if I have anything that has happened in a surgery, so we have normally a morning surgery or an afternoon surgery. If I were to experience anything within my surgery that was difficult at the time, I would always be able to speak to a colleague and sort of offload or, discuss a case. If there was something that was worrying me or my management, I would always go and discuss that. So I'm very, very lucky that I feel completely able to talk to any of my colleagues about anything like that. And then, yes, I have a really good I have a very supportive husband. I've got a very supportive family, and I've got a lot of really good friends, both medically, who are in the medical profession, and non-medical. And I am very able to share concerns or worries or anxieties with those people as well. And then, as I said, I have a GP peer group where I can talk to other people as well. And I think for me, that's how I manage stress, is by speaking to my friends and support network, really.
Have you ever had a moment, a special moment with a patient that stayed with you for a long time and maybe made you think about something?
Oh, all the time. I can remember.
I'm asking because, sorry to interrupt, encounters with doctors are usually very formal, and you leave the appointment thinking you haven't left an impact, or there was no impression made, kind of thing.
Yes.
We didn't see emotions from doctors.
Yes. And again, I think it probably depends very much on that patient-doctor relationship. But I certainly, I can still remember patients that I looked after in my very first job that I did as a house officer. And I can remember patients all the way along that have, for lots of different reasons, have had an impact on me, whether they've changed the way that I've worked, where there've been outcomes that have been unexpected, where things have happened and I've reflected. So all the time, I think it will be quite a common occurrence for me to come home and be thinking about a particular patient that I've seen that day. Sometimes it will affect my sleep. I'll worry about a patient. You sometimes worry about the patient. You sometimes worry whether you've done the right thing. And that's just part of being a doctor, I think. That just comes with the territory. It's not something that significantly it affects me, but I think just as a human, you can't possibly do this job unless you are, you're going to be affected by some things at some point.
In Egypt, we don't have GPs. We don't have the concept itself of general practice. You yourself as a patient assess based on your symptoms, which kind of doctors that you need to see. You go to a private clinic, you pay. Okay, you wait in the lobby for a few hours till you see what we might call here a consultant, not a GP consultant specialist. And that's it, as simple as that. But of course, you have to pay for the treatments. And if you're not rich, you're not going to get a good treatment. I remember when I moved to the UK, and I had the first medical thing that I had was a big rash in my hand, and I assumed that this is dermatology.
Yes.
So I had already been registered in a surgery, and I called asking to see a dermatologist. The lady over the phone said to me, in a Yorkshire accent, darling, you don't see a dermatologist, you see a GP, and the GP will decide what's going to happen. I think my ex-husband now, he thought I was clever enough to know how things work, and he didn't put the time into educating me in life in the UK. How do you see general practice changing, positively or negatively, in the future?
I think there is definitely a move now to create more posts within a general practice setting for different types of healthcare worker. So instead of now maybe seeing a GP, you might now see an advanced care practitioner, a nurse practitioner, somebody else might see you. They may be able to help you with common health complaints and may then refer you on elsewhere. And GPs perhaps are now becoming slightly more specialist in looking after perhaps more complex patients, more chronic disease management and things like that. So I think that possibly is a way that things are changing. It may well be as well that we use more technologies, artificial intelligence technologies and things like that to help us diagnose things. We use possibly that type of equipment in terms of our note taking, but maybe that will then help in decision making as well.
So, and with the rise of AI and virtual consultations,
yes.
do you think the NHS should or will rely on these digital techniques in the future, despite the fact that they are faceless, right? And they lack the human touch?
I think just in terms of the demand and the volume that we have to face, they may well play a good role in being able to triage. I know certainly for things like imaging now, they're using AI to be able to prioritize which images need a more urgent review for somebody to then take over the work and prioritize. And that to me seems quite sensible. So I think if there are ways of being able to use it, I don't think it necessarily takes away from that face-to-face contact, but it might just mean that certain patients, certain conditions are picked up or prioritized in a way that might be a more efficient way of managing the system.
I appreciate that patients have a role as well in supporting and maintaining the NHS. I think, again, my own observation is that we as a nation did very well during the pandemic. What can we as individuals do to support and maintain the NHS?
The best thing patients can do is really just to try and look after their health and take responsibility for their health themselves, really, more than anything else. So if people are healthy and therefore not putting themselves at greater risk of having illness and disease, then that will place less burden on the system. So that's the main thing. Also, just not wasting resources. So if you do have an appointment, if it's something you don't feel you need any longer, just make that phone call and cancel it rather than just not turning up. Just simple measures that mean we're not in any way wasting the resource.
Absolutely. Another observation of mine is that the NHS is not so good at preventative care. To my knowledge, we don't have, the NHS doesn't have a newsletter service. I actually called my medical centre and I asked if there is a newsletter that I can sign up for. And the lady said, no, look at the NHS website. But we only go to the NHS website when we are already unwell and looking at something. But a newsletter service is something very easy to implement, and all small companies now have that. So why is it difficult to invest more in preventative care?
That's a very good question. And I think it's probably at the moment just left very much on an individual level. So I think individual practices, it's down to their own initiative, really, whether they're prepared to put these things in place rather than them being a standardized sort of preventative information service. I don't know how much of responsibility that is on the government, on the, whose ultimate responsibility is it to...
It's more admin work.
Yes, yeah, to look at that. But I completely agree. I mean, I agree with you, and I think this all is based on education and information, isn't it? It's making sure that we are educating people and providing information to people, and it's a public health issue. And there have been cuts in that area. There have been cuts to public health, and we do need to perhaps put more investment into that so that we can explore that a bit more.
Yeah. Absolutely. Fiona, you have 3 children. And you work as a GP in 2 different places. You lead initiatives and you set up clinics. You must have a lot of passion for what you do. Give me your best time management tip from a mum to another mum. How do you do this?
Oh, I don't. I wish I had
Please.
I wish I had an excellent tip I could give you. Honestly, it is. I mean, you just have to be as organised as you can, and make sure that you are very skilled, as we, in trying to balance all these things out. But I think, we often, I often hear women talking about this whole idea of sort of having it all. And I think it is understanding that when you are busy and you're working, then that does sometimes take away your time from your children and your family life. And it's just important to constantly monitor that and make sure that one is not really taking over from another and that you feel comfortable. But I wish I had a great answer. I don't feel like I am always balancing it particularly well. I'm sure I could do better in lots of areas, but all I can do is I can say I try my best.
Absolutely. Fiona, thank you so much for your valuable insights with us today about women's health, sexuality, sharing with us your experience in the NHS and the conversation that you have contributed to about gender health gap is so timely and ties with the whole gender discussion that we're debating. Thank you for being with us.
That's fine. It was a pleasure.
Today.
Thank you for asking me. Thank you.